Our next speaker is Ifeoma Ozodiegwu from Northwestern University, USA.
So hi everyone, I want to start by thanking the organizers for the opportunity to be part of this forum and to thank my group and the support that I've received in developing this work and all the other parties that were involved, which includes people from the Institute of Disease Modeling, the WHO, as well as the National Malaria Program. So today I'm going to be speaking about the work that we did in collaboration with our partners to develop a mathematical model to guide global fund applications in Nigeria. Next slide, please. Just one more. And so, well, to give you some kind of background or context into what motivated this work, as many of the speakers have already highlighted, malaria transmission across Africa is becoming quite heterogeneous. And in Nigeria particularly, in the past, the approach to the design and deployment of interventions have been typically uniform. But because of this growing heterogeneity that we're seeing in malaria transmission, and the fact that we're also seeing increasing diversity in vector control tools, and the fact that we're also seeing issues with funding or limitations in funding, there's been a push towards moving towards tailored interventions. And so I show you here the 37 Nigerian states. And so the goal is to designing interventions for each of these 37 states. So next slide, please. And to dive a little deeper on why it's important to take this more targeted approach, the reason is because we want to be able to identify the most optimal intervention for these individual states and allocate our resources to those that need it the most. Next slide, please. And so this is where my group came in. The NMCP or NMEP in Nigeria had already been doing previously national strategic planning by stratifying interventions and allocating interventions, like I said, in a uniform manner. Of course, with the exception of SMC, which is typically given in areas that have seasonal malaria transmission. But they had already stratified interventions for their upcoming or their new global fund application, which was going to cover the years of 2020 to 2024. And what they needed was, how do you identify the best set of interventions for different LGAs? And then LGAs in this case is an administrative 2 unit, and there are 774 of them. And so the task is really non-trivial. So identifying the best set of interventions for these 774 units. And in many cases, they had several questions. Where should we be expanding SMC? Should we give SMC in a particular area, or should we give IPTI? And there was also questions of whether urban areas should continue to receive nets. And so these were some of the questions we wanted to use a quantitative approach to help them answer. Next slide, please. And so the goal of this project was to predict the impact of the set of intervention mixes on malaria mobility and mortality, so prevalence, incidence, and mortality and deaths. And then for each of these LGAs to aggregate the results up to the state level. Next slide, please. One more. And so to do this work, first we had to use an existing model. This model is an agent-based model that was developed by the Institute of Disease Modeling. And it's a complex model of malaria transmission that combines a vector, temperature-dependent vector life cycle model, and then with a model of human disease and immunity, as well as intervention effects. Next slide, please. And so we wanted, as part of our work, to calibrate this model to recapture malaria transmission dynamics in the past, as well as predict the impact of future interventions. And so there was going to be a baseline period, which was going to be prior to 2010, where we want to capture the intrinsic potential of each of the LGAs to support malaria transmission. The next step was between 2010 and 2020, which was the period where there was most of the interventions, because they were before 2010, most of the interventions had not been carried out. So the interventions I'm speaking of here are things like IBTP, SMC, as well as net distribution and IRS. And so we wanted to capture these interventions. And when we did that, we also wanted to validate the model. And then finally, to use this same model to predict the impact of the strategies that the NMCP had proposed. Next slide, please. And so there are key things that we wanted to capture in this model. First one was the seasonality of malaria. And we used data, routine incidence data from Nigeria. And we also wanted to capture transmission intensity using the demographic and health surveys, as well as in intervention effect sizes. We did that using information from the literature, coverage data from the DHS, as well as the distribution schedule from the NMEP. Next slide, please. But however, like I pointed out, we have 774 LGAs. And with the issue that arose was that there was hardly data for several LGAs. This map here depicts the PFPR, or the parasite prevalence in Nigeria from the DHS in 2010. And you can see here that many LGAs had no data. So we had the challenge of trying to overcome this problem. And so my colleague, Monique at IDM, next slide, please, work towards grouping these LGAs using a clustering approach. And so the idea here was, if we were to group these LGAs by epidemiological archetypes, then we can begin to parameterize them at the archetype level. And so we had 774 LGAs, and we grouped them using the rainfall data, the temperature suitability index data, the PFPR from before 2010, as well as ITN coverage data from prior to 2010. Using this data, we clustered these LGAs, and we ended up with 22 archetypes. Next slide, please. And so, like I mentioned before, we needed to capture seasonality. And so this here is showing the fit, the seasonality fit that we included in the model. And so this was for one of the archetypes. And you can see here that this is a good match. So next slide, please. And so the next step, of course, was to capture prevalence. And so we use a maximum likelihood approach to be able to capture the PFPR amongst under 5 using data from the DHS in 2010, while accounting for the insecticide net treated net coverage in that period. Next slide, please. And so, like I said, we had a baseline period. And so what I described was the baseline period. So we've captured seasonality, we've captured transmission intensity. So now we want to capture the intervention effects, and this from between 2010 to 2020. Next slide, please. Next slide, please. And so to do this, we needed to capture the history of interventions in Nigeria. And as you can see here, several interventions were done. Some were done in a few states, some were done across different states, many more states, something like ITNs, as you can see. And so we needed to get coverage data for each of these areas where these interventions were implemented. Next slide, please. So I show here an example of some of the challenges, one of, again, a lack of data challenge or poor data that we challenge that we had when we were trying to capture intervention effects. Going back to the DHS for case management in this scenario, we didn't have sufficient data for the time period we were interested in. And so this here shows that in 2010, there was hardly any data, similarly with 2015, and this is for each of the LGAs. Next slide, please. And so to overcome this challenge, what we did was to firstly use the data in the areas that had data from the DHS. And then in the areas that didn't have data, we aggregated the data across archetypes and substituted that for the data in those LGAs that did not have sufficient data. Next slide, please. And this here is also one of the ways that we try to calibrate IT and effect sizes in the model. So what we did here was that we used the MAP estimate of permethrin resistance. And so we constructed a relationship using the Churchill model between the bioassay permethrin resistance and use that to estimate the ITN kill rates and as well as the ITN blocking rate, accounting for this resistance in the model. Next slide, please. And so once we've completed all the calibrations, we want to, the next step was to generate historical trends of malaria prevalence, compare that with the existing data, as well as make the future projections that the NMCP requested. Next slide, please.
2-minute warning.
And so here is the results of one of the results we shared with the NMCP for a particular state. You see here different 4 scenarios that we ran in our model. And so you see that the business as usual scenario was the NMCP wanted to know what will happen if we continued the current practice of intervention deployment, and what would happen if all interventions, that's the 80% effective coverage scenario, what will happen if all interventions were at their maximum, or all LGAs received these interventions at the maximum level. And then what would happen if for the funded scenario, what would happen in particular if we included interventions at a level that we think is realistic, and particularly included SMC, and compare that with a scenario that did not have SMC. So we were able to show them that the scenario that had SMC performed better than the scenario without SMC. Next slide, please. So in conclusion, I think it's important to highlight some of the lessons we learned as we went through this process. One being that it's important as part of country engagement to actually listen to what the NMCP has to say, because some of the questions they had helped us to improve our model of structure and assumptions. And it was also important that the NMCP, we were transparent in our work, and that the NMCP really understood what was guiding the assumptions that we were making, and also we were able to get feedback from them to drive our assumptions. And then finally, I think it's important that for sustainability, that local modeling expertise is built. There's an emphasis on capacity building within endemic countries, so that individual countries can begin to answer their own questions, and also continue to use quantitative techniques to guide national strategic planning. So that's all I have, and I look forward to your questions.
Thank you very much for your presentation. So we have a question in the chat. Have you been able to build uncertainty into your models? These appear deterministic. Has any stochastic modeling been performed?
Yeah, so this is actually a stochastic model. And so uncertainty is actually put into the model. So uncertainty in our parameters, those things are also incorporated in the model. One way I think would want to see, and of course, having given a stochastic model, you do several runs. So there's also uncertainty incorporated into the runs as well. But I think one way also we have been thinking of including uncertainty in our results. So if you have different parameters or potential parameters that within our model, we can run them and then come up with different, for each of these scenarios, have a set of results that show the uncertainty in our predictions. So I think maybe that also would be a good way to show our uncertainty as well.
Okay. We have time for one last question in the chat. How much do you expect your work to influence decision makers?
Our work is actually in collaboration with decision makers. So this was results that we presented to the Nigerian Malaria Elimination Program, and it helped to guide decision making for how the Global Fund applications were written and the proposed interventions that were chosen for funding. So this work is actually in collaboration with them.